side of your screen. Please close any other applications or windows that you are not using to conserve bandwidth. And this webinar will be recorded and uploaded to our website by next week. So I'm excited to introduce our presenters. Today it's just Drs. Painter and Lightford. I think Dr. Campbell said she was stuck traveling. I think that's what Dr. Painter told me. So they serve as interprofessional faculty in the Center of Outpatient Education Program at the Lewis Stokes Cleveland VA Medical Center. Drs. Campbell and Lightford previously completed the COE program as learners themselves prior to joining the faculty, and Dr. Painter served as the Associate Director of Psychology. Medical student Mia Wayne joined the group as a scholar from the Interprofessional Scholars Collaboration in Teaching and Learning through Case Western School of Medicine. Within their current roles, they specialize in curricular development and have a specific interest in developing innovative curriculum focused on social determinants of health. And with that, I will kick it over to the presenters.
Well, hi, everybody. Thank you so much for having us. Come on, we could do a quick intro before we get started, if that's okay? So I can go ahead and start. My name's Elizabeth Painter. I'm actually a clinical health psychologist. And I trained at the Lewis Stokes Cleveland VA and kind of have moved on working there and have had the opportunity to do a lot of interdisciplinary education and our focus in social determinants of health.
And I am Kimone Lightford. I am an internal medicine trained physician. I'm currently a hospitalist. And like Claire mentioned in the introduction, I completed the Center of Excellence program. And so it was my first introduction into sort of a non-traditional residency education track, and really opened my eyes to so many things that I wouldn't have been exposed to before. And so once I finished residency, I decided to join as faculty. And then eventually we had the opportunity to create this curriculum, and it's just been an eye-opening experience for all of us. So I hope that you all enjoy our talk today. And we're really going to be focusing on just some general information, but then really showing you how we took this particular lecture through the first iteration and what changes we've made and how we've had to pivot. And so I hope that you gain a lot from this.
And please don't hesitate to ask questions, put them in the chat, whatever you need. We're glad to interact in that way, especially with a smaller group. So I'm going to try and share my screen. So bear with me. This is probably a little bit past what I'm capable of doing. Okay, you guys you can see my screen? Okay, perfect. So as Claire said, these were just our intro pieces. I'm going to see if I can get give me 1 second to see if I can get this up. Here we go. Okay, so what we're going to talk about today is sort of the process mapping process as we developed a specific lecture about incarceration and use that as a social determinant of health. Turns out that every time you put together an innovation, it doesn't always work perfectly the first time around. We had gotten lucky a few times, and so we were hopeful, but this definitely took a few iterations. And so we just kind of wanted to talk a little bit about our program and then about what happened there. So as I described, we're going to talk a little bit about our curriculum broadly, the program that we come from, outlining the perceived knowledge gaps that we've identified ourselves or our learners have identified, outline the development of this particular curricular activity, and then describe the evolution of it and kind of where we're moving on forward from there. So as we keep mentioning the COE, that this is where we started. It used to be called the Center of Excellence. It's an educational initiative that was started by the Office of Academic Affiliations, or OAA, within the VA system, with really the goal to train future outpatient healthcare professionals in a team-based model, in an interprofessional way. Because, I've seen the graphics before from like the World Health Organization, et cetera, and there's always this idea that team-based care is the way to go. But when you kind of look back through training, a lot of times it's expected, but not really taught. So we were trying to find ways to navigate that scenario to make people more effective at being on teams by the time they were going into practice themselves. I think the other complicating factor, particularly for our medicine trainees, is that the focus had historically been in training on acute care medicine. Here's your symptom, this is what we do to fix it, moving on. And as everyone knows now, particularly with the amount of chronic disease management that we're trying to do, if that worked, none of us would have jobs, first and foremost. And it just takes a different skill set to be able to navigate those folks, particularly in the outpatient setting. So we wanted to have a unique place where people could learn the skills they needed to practice outpatient medicine, to practice team-based medicine, and take care of these patients that we know have really complex psychosocial pictures. So we were one of the initial 5 pilot sites across the country that were funded by this initiative. The others, as you can see, were Seattle, Boise, San Francisco, and West Haven. We had a $5 million grant to work on this program. We've actually gone through a couple cycles of the grant. And we're very lucky to be able to participate in this. I feel that deep down in my soul because I think I've never seen anything quite like it. And it was something that was really important to me to think about teaching social determinants of health and otherwise to interdisciplinary learners. So our learning group, it gets complicated. So this is a crazy color-coded spreadsheet when you lay it all out. But we have a variety of different kinds of learners. So we have some learners that come for 1 year, and then our medicine residents come for 3 years. So let me start with the 1 year folks. So we have our nurse practitioners, both residents and students. Pharmacy residents, they're usually in 2nd year ambulatory positions at that point. Behavioral medicine, so these are health psych postdoc residents. Social work, our master's students, and then we have bachelor students that are nursing students. So those folks each come essentially for their academic year or 1 calendar year, depending on their program. They're a little easier to organize because they're there solidly for 1 year. The next kind of tier of folks is our MD residents. So we have PGY1s through PGY3s, and they come on alternate hospital rotations. So they alternate hospital, outpatient clinic, but instead of doing 2 weeks here, 2 weeks there, we were able to get an ACGME waiver so that they come for 3 months to each section. So they're in outpatient continuity clinic for 3 months, and then they're in inpatient settings for 3 months. The other kind of cool thing that they get to do is they pair with another, either NP or MD, to have a panel of patients. So they'll get continuity over 3 years with the same panel of patients, which I think is a valuable learning experience in terms of thinking about doing chronic care management over time. And then we have an interprofessional faculty that helps with curricular design, teaching, and then also staffing in the clinics because we use a resident-run clinic to work with all of these providers together. So that was the Center of Excellence as it was when it was grant-driven. That national grant funding has now ended. And thankfully, our program has been kind of taken over by the hospital. So it's now part of regular day-to-day practice in our VA. So we changed our name. We went from the Center of Excellence to the Center of Outpatient Education, also the COE, conveniently. And so we had similar goals for what that looked like in terms of what our goals were for interprofessional education, for topics, for all of those pieces. But it did give us a little bit of flexibility to meet the learners' needs. Historically, when it was part of the grant, we had very specific categories that we had to hit for training, very specific things that we needed to target, many of which had a lot of value and we kept. But this also allowed us to add in other things that we thought were important, and which is we'll start talking about our kind of social determinants of health curriculum in that way. So the structure, like I mentioned, is that everyone's working in clinic together. But the exciting part was that we were able to do a 4-hour academic half day with all of the interdisciplinary learners. So every Friday morning, we come together to do different kinds of didactics. Some of them are more content focused, some are more team-based, some are research focused. There's all different kinds of things that have been developed as part of this year-long curriculum. And then also each profession gets their own individual professional appropriate clinical learning within their rotations as well. Okay. So as I mentioned before, previously our grant funding kind of dictated a little bit of what we taught and what we did, or at least how we conceptualized what we were doing. But over time, we realized that there were some learning gaps, and now we had the opportunity to do some more formal teaching in those other areas. And this is where we came together to develop our social determinants of health domain. We also at that time added a professional satisfaction domain and a leadership domain. All of us that you see involved here were obviously part of the social determinants of health domain. And we realized that there was no formal curriculum. We had some scattered lectures. We tried to address things that we thought were important, like there was a quote, social justice lecture, we had climate change and health, but there was no sort of educational arc to what we were doing, or, kind of a conceptual model of what we were trying to cover and what we wanted to make sure people really understood at the beginning of their training versus the end of their training. So this is the vision statement that we created for our curriculum, the social determinants of health curriculum broadly. So to understand the interconnectedness of societal and cultural influences on the patient's interactions with the medical community, create awareness of how health policy, legal precedent, societal challenges, and environmental factors affect clinical decision making.
Elizabeth, I'm just going to interrupt you for just one second.
Yes, please.
There is a comment in the
yes.
chat that
sorry, I can't
there's
see
some
it.
microphone disturbance. So they're asking, can you please reconnect your microphone because they're not able to hear you that well.
Better?
I always can hear you, so I'm not sure.
I can also hear you fine. Is anyone else having any issues?
I could do it all in an interpretive dance.
They just
much better. So we're good.
Okay, good.
Okay.
It's also possible I occasionally hit my mic, so I apologize if perhaps I did that. Okay. So this was kind of our overarching goal and vision statement for our curriculum. Now it took us a few iterations to get there, I'll be honest. It was quite a process to really think about what's the most important thing to cover. So, it's interesting because we thought about where do the gaps lie when we think about what people are reporting to us, what we're seeing in clinic, and even in the literature, when we went back and looked, it's pretty widely accepted that healthcare providers are not always well versed in SDOH. Some more than others, of course, but it also kind of alluded to the idea that clinical experience alone isn't enough to properly prepare and educate our providers on how to engage folks. Because, and I thought this was interesting, just the idea that treating patients that are negatively affected by SDOH has shown to have a negative effect on medical students. And so there's high correlation there with dissatisfaction across the board. But we felt like that we really needed a concrete way to formally teach these pieces. And we know that when formal training occurs, so do changes in behavior. And that's what we really wanted to get at, because I think sometimes social determinants of health can be a little bit of a can of worms, right? If you don't ask the question, you don't open the can of worms, and then you don't have to deal with it. Now, I don't think that ultimately ends in good patient care, but I think that has been a strategy that has worked for people. And so we wanted to make sure to toss that can of worms right out in front of everybody and kind of make sure that people felt comfortable navigating those things when they did come up, because realistically, that's going to happen. And so, then we thought specifically when we get to this lecture. So we came up with a host of different talks and different interactive activities that we do related to social determinants of health. One of the places we realized there was another gap was thinking about incarceration in our population. And why was that important to us? It turns out that when we looked at our learners, most of them were treating folks who either were recently incarcerated, headed towards incarceration, still on probation, and they didn't have much sense of what that meant or how that was impacting people's health. So when you look back to the literature here, we know that there's a negative relationship between incarceration and multiple health conditions, everything from heart disease, malignancy, infectious disease, you name it. The experience of incarceration, the exposure of that generally has a greater effect on health than the length of the incarceration. And incarceration is associated with worse health for all formerly incarcerated persons compared with never incarcerated persons. That's a pretty broad statement, but I think it's a pretty powerful one when we look at, more systemic and bigger groups of people. I think that's really important. And so, we just used a few different statistics to kind of highlight to our crew and to everyone else why we wanted to do this. There have been changing rates of incarcerations over the years that are due to a lot of political and societal pieces that I think are important for our learners to understand how and why that's happening. Obviously, healthcare workers are more likely to encounter patients who have been a part of the legal system than not. And there are a lot of unique barriers that come with reintegration post-incarceration that I think a lot of people are unaware of. Dr. Lightford, did you have something too? You're muted. There you
Yes,
go.
so sorry. Yes, I would just add that we included some of these rates because we knew that so many people, and myself included, were not aware of the current rate statistics. And so this for me was not something I was ever exposed to during residency. And so that's how we really, when we were sitting at the table brainstorming, we said, what do people need to know? So yes, I'm so sorry.
No, that's perfect. And will you do me a favor and keep an eye on the chat? I can't open it and have the slides as well. Thank you. Okay. You know, so this just goes again into thinking about different health effects of incarceration. So the idea of the chronic stress and the impact that has on your body over time for folks that are incarcerated for months to years at a time, the disease groups that go with that kind of chronic stress, the rates of infectious disease, of course, because of exposure, and then also the impact of what does incarceration do to somebody's life in terms of their families, their jobs, their finances, all of the different components that come with it. And then also the marginalization of folks trying to find jobs afterwards, trying to pay even just legal fees, let alone all the bills that come to someone who hasn't been working. Housing insecurity. And then we even looked at things like obesity, where it's hard to have a low sodium diet for your heart failure when you're in prison and you get to eat what is served to you. And you get a certain amount of physical activity and a certain amount of stress that can certainly play into those conditions. So these are all the things circling through our brains. Then we also wanted to think a little bit about making sure that people were aware of the resources. So things like legal aid, which I'll be honest, I was not well versed in initially. I know I'm like, oh yeah, that's a thing you should do, right? But why is it so important? So when legal services are effectively used to address social needs, people are less likely to be hospitalized. They're more adherent to their medications and their medical recommendations. They have lower levels of stress, and they generally will remain more stably housed, which is a huge deal when you think about, I always think about Maslow's hierarchy of needs, right? It's hard to manage your diabetes when you're worried about your housing, what you're going to eat, those kinds of things. So if there are pieces that we can put into place to help people meet their basic needs, we have a better chance at helping them with their health. And you can see too the drop in ED visits, which is always huge, both from a financial perspective of institutions and also just more broadly in terms of how people are doing. Okay, so knowing all of those things we were interested in, we went ahead and developed our first rendition of a lecture or a training opportunity for our interdisciplinary learners. So we really wanted to focus on, there's a lot you can talk about in terms of incarceration, but we wanted to think about how is that impacting people's health? What do people need to know? So take one of our lecture. These were the goals and the objectives that we outlined. So like we mentioned, we looked at the rates of incarceration, what that meant for the general population and the veteran population, which obviously us working in a VA, that's a big deal. Describing the impact of legal involvement, as we described, on the physical and mental health, economics, housing of some of our patients. Figuring out how do inmates actually receive care when they're incarcerated. Explaining the federal fugitive felons policy and how it could impact patient care. And then also understanding the importance of the medical legal partnerships. So it was a lot to take on, but everything that we thought was important. This is a little bit of foreshadowing that may have been too much. So when we thought about strategies to do this, we wanted to expose folks to foundational information, making sure we got the legal component, the medical ethics component. We wanted all of these statistics presented. We discussed legal aid in depth, and then we focused on knowledge delivery. We really dove into making sure that people had the access that they needed to all of this information. So these are some example slides. So speaking of foundational information, we realized that there are a lot of folks who didn't know the difference between jail and prison, what those terms look like, and what that means in terms of people's expectations of healthcare and if they were to tell you where or how they're being incarcerated, having some understanding of how that might impact their lives in different ways. So we tried to make it pretty straightforward so that people had that understanding. Then again, we talked about kind of legal issues are ethical issues, and how do the medical ethics kind of combined with what we know as medical and other providers to act in the interest of our legally involved patients, especially now that we have a sense of how many folks are probably have been involved in our legal system at some point. You're all good readers, so I won't go through this whole slide for you, but the idea is really just recognizing what our 4 principles are, but also ways in which these principles may have historically been a little bit problematic in this setting. And so it's important to keep that in mind as we move forward. And I thought this was a good point, the one in the corner, just the idea that prisoners have historically been mistreated and denied their autonomy and rights in this country. And it's critical that we acknowledge this past so we never have to repeat it in the same way. But then we think about where things sort of started to go awry a little bit. So when I looked back at some of the materials we had for our first iteration of this talk, I realized there were multiple slides per topic, which was wonderful in that it was a great deal of information, but it turned out to be very nuanced information. So in this one situation, this would be a helpful piece of data. And ultimately, I think we lost the forest for the trees. So instead of taking these big chunks away of these are the big components I need to know, and this is how I would best help this patient, we dove too deep into very specific things. So for instance, legal aid. By the time we were done, I was a little overwhelmed by legal aid, to be honest with you. And what I realized later was what I needed our learners to know was, this is what legal aid can do. This is why it's important. This might be how you refer, and start there. But as you guys may have found, trying to design education around social determinants of health is, we feel passionately that all of it's really important. And so sometimes I think, especially at a first go, we're so invested in making sure that everything is there so people have the resources, that we can lose folks in that way. We got into a lot of technical specifics. So how you would fill out certain paperwork, what specific resources, how you would get them, that I think you can get a little lost in that, which I illustrated here, just in the sense I actually remember the moment in one of the lectures where I saw everybody's eyes glaze over. It was like a piece of paperwork came out about how you would do that. And everybody just sort of zoned out. And unfortunately, I think the risk of doing that, while it would have been a great resource to go back to, is sort of the old Charlie Brown cartoon, in the sense that once people glaze over, all they hear is rah, 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 for the rest of it. And so consequently, I think that I don't want to say did more harm than good. I still think there were good pieces that came out of that, but I think we lost an opportunity with that lecture in terms of how we considered providing the information and helping folks learn those concepts. So like I said, there were some strengths. It was a detailed presentation. So I think it was great that people had it for review. So if they came across a patient where they needed some help, they could go back to the presentation and see if there was something there that was useful for them. However, I think by putting that much emphasis on those nuanced aspects of the legal system, we lost the forest for the trees, like I mentioned. I think we also may have made some assumptions about what people knew coming into the talk. We had, with our interdisciplinary cohorts, people know all different things or have had all different lived experiences. And I found that there were folks who had not had much experience in this at all. And so diving straight into the specifics wasn't as helpful as providing some of that baseline information. And again, the irony is I'm doing it as we speak, but it was really a heavily didactic lecture-driven talk. And, as we transitioned, particularly, I think this was striking when we transitioned to all virtual teaching during COVID. It takes a different kind of engagement to get people really invested in the context of doing videos and when you can't see each other and those kind of things, that I think we really lost folks for the sake of doing a more lecture-driven talk. Okay, so now I will toss it back to Dr. Lightford, who will talk a little bit about how we kind of went about take two.
So because as Elizabeth said, when we did the first lecture the first time, we realized like we gave so much valuable information, but the feedback that we got from the learners was, well, okay, well, what do I do now when I see my patients? How do I bring up the topic? How do I talk about it? You know, it really felt like they were asking us for more clinically relevance. All of it was relevant, but clinically relevant takeaway, you know, what can they grab and actually utilize? And so we went back to the drawing board and we said, okay, how do we make this more concise? What can we cut out? What do we need to keep? And what were some of the stigmas that we realized came up during the talk? Because of course, we had our own knowledge that we came in with, and you know, we put together this presentation. And just to also remind you all, our social determinants of health group is also interdisciplinary. You know, I'm medicine, Dr. Campbell, who's not here. She's also a physician trained with me. And then Dr. Painter is psychology. We had another psychologist and we had a social worker as well. So that was our entire group. And so the first go around, we had Pam, our social worker. She really put a lot of work into the social work aspect and really gave a lot of resources, but our learners said, well, when we got back to clinic, we really didn't know how to start the conversation. So that's sort of how we went back to the drawing board. We also realized that we needed more audience participation. You know, you never want people's eyes glazing over and whatnot. So, what on the future slides, what I'm going to have, oh, Elizabeth, you can go. You can, I forgot that I'm not advancing, I'm sorry. So we're going to have examples of the exact slides that we actually use. So one way to get audience participation as you're building your own lectures or your own educational materials is true false questions are very easy, and it really, they're quick. So we had a few of these sprinkled into the second iteration of the lecture. So we had this true false question. You all don't have to answer, but the question was, veterans have a higher rate of incarceration in comparison to the general population. You can go to the next slide. And the answer is false. Veterans actually have a lower rate. And the reason we included this is because we realized that some people, some of the stigma or bias that exists in the community is that when veterans come home and they have sometimes have a harder time readjusting to civilian life. Sometimes they're at higher risk for housing insecurity. The stigma that they have higher rates of mental health issues and higher, you know, all of those sort of things. Some of our learners thought that meant, or that led to them having a higher rate of incarceration than general population. So this true false question was to sort of dissipate some of the stigma, but also get the conversation flowing. And also, and for your learners too, you want to make it as relevant to your clinical population as possible. So in our lecture, we made sure that we were giving information about general population, but also our veterans, because that's ultimately who they're seeing in clinic, you know, since we're at the VA. And you can go to the next slide. So we also spent a lot more time focusing on reintegration issues. We realized that when what our learners were saying is that I'm seeing this person in clinic, but I'm not really understanding the full context of what they're facing as they're trying to reintegrate into society. So we talked about, and you can see some of the things we included here, but we tried to educate them on the fact that, so for example, let's take the financial issues. Not everyone is aware of how many legal fees you have if you're exposed to the justice system in any way, shape, or form. So we talked about the fact that there are many legal fees and that while you're incarcerated, you're not working. So now you may have back pay that you need to pay back. So you may have child support issues, back fees, bank account, you know, your bank account overdraft fees, so many fees that our patients may be facing. And so we discussed how, as an example, financial instability means that our patients have to choose between paying some of these fees or paying for their medications. And so when you start putting these things into context, it really brought about a little bit more discussion for our learners, and gave them a few more thinking points when they're seeing the patients in clinic and the patient, because we talked about saying, we've all heard the label non-adherence, and we're really trying to get them away from writing in the chart and saying or presenting this patient is not adherent to their medications, and taking one step further to ask the question, well, why? What's going on? How can we help? And I think we were trying to focus on having the learners really take a comprehensive look at the patients, especially if they know that they're facing reintegration issues. We also talked to them about the chronic diseases, like we mentioned before. They are under a tremendous amount of stress, and so are their families. And they have reintegration comes with fractured family supports at times, not all the time, but or strained family support. And so sometimes, if you're seeing your patient in clinic, and they may need to be admitted to the hospital, but they don't have the social support, they're scared. Anybody who has to go to the hospital, you're scared, you're not sure what's going on. And then when you throw in, maybe they're recently released from jail or prison, and they have to make a certain court date, that is something that's stressful. That's something we have to think about in the context of their health. And we also talked about the requirements people may have after release. And so a lot of this example slide we have, this was a really important one that we included in the second go round of this lecture. And I think that helped the learners walk away with more clinical context to reintegration. Next slide, please. So like I said, and I think this is important for all of you as well. It's okay, I remember where the slide is. But so
Fixing it.
no problem. We really wanted to make sure that we brought awareness to some of the VA specific resources. So, and all of us, myself included, I was not aware of this Veterans Justice Outreach Program. And so that is a resource a very robust resource actually, that the VA has to help our veterans, to pair them up with a social worker and really help them navigate there is actually a veteran specific court too. And in the first go round, we had a lot of discussion about that. And that was us filling in a knowledge gap that the learners had. But this go around, we sort of just mentioned it to them and said, if you need more information, then, speak to our social work colleagues and they can really help. But we wanted to make sure that the learners knew that this program existed, but also knew, hey, this program exists and there's a social worker that can actually help you figure out what's going on with where they're at in the legal system process. And how can we get them better services for housing insecurity? How can we help with so many other things? But it's really one of those knowledge gaps where it's, if you don't know the service exists within the VA, how can you even refer your patient to the right person? And so it was important to us to really, really hone down. This was part of how we honed down what we need to include in the lectures. And so we really made sure to keep this for the veteran specific content. Next slide, please. So I really want to spend some time on here, and it's not necessarily the case. I will read the case to you all, but it's more that this case highlighted, this case brought about a lot of discussion during the presentation. So we talked about the case, we talked about the answer will be on the next slide too as well, but having cases in the presentation really helped with audience engagement. After we discussed this case, some of the learners brought up their own clinical scenarios. They brought up some of their difficult cases that they had issues figuring out what care did the patient get while they were incarcerated. Who do I talk to? How do I figure out what's going on? So in this particular case, it was a very unique one. It was actually Dr. Campbell's patient. So the case reads, she had a 25-year-old transgender female, history of HIV and substance abuse, which was in remission. and had been recently initiated on hormone therapy with her PCP. She also followed with the ID clinic for her HIV treatments. And then subsequently, she was arrested for multiple drug charges. So in the past, the patient had attended the substance abuse court several times, but after the most recent offense, she was transferred to traditional court. And just to make sure everyone understands, what they're saying is she was in the veteran specific court at first, but after a certain amount of times, it's decided in the court system, the veteran sometimes then has to go to a civilian court, which we're a little bit more familiar with. So that's what happened to her. So while awaiting trial, she was incarcerated. Now, after her release, she states that during incarceration, her hormonal therapy regimen was completely changed. Her HIV treatment was continued as originally prescribed. And so the two questions we had for the group were, how do you find out or confirm her treatments, and how is healthcare provided during incarceration? Especially that second question was really illuminating, because that's how we had gotten written feedback and survey feedback from the learners before that, but that's how we really, in a group discussion, learned that they had no idea. They had no idea who provides healthcare. How often do they get healthcare? Can they get different medications? What's on formulary? Is there even a formulary for the system? So many things that we realized people just didn't know. And that has to do with exposure, but it's also teaching social determinants of health in a residency program or in any program is, even though it's so important, it's not something that's widely done. And so people just had no idea. So you can go to the next slide. So for us here in Cleveland, one of our local hospitals, Metro Health, they are the ones that provide care for patients incarcerated. So we included this slide, and you all can read it, I won't read it to you, but we included this slide to provide the knowledge to the learners of how do people get care, and to also let them know that you can access their records, because we're able to see Metro records and Metro can see our records. So in this particular case, they had to change her hormone therapy because that's what was on formulary in the jail. So it wasn't changed for any sort of other reason. It's a cost issue. But that was really eye-opening for people. And later on, afterwards, people said, I had no idea that I could access those records. And since then, they have come back. Some of the feedback we've gotten is that I'm really glad we had that lecture, because now I was able to do that for my patient in clinic. And that was what we really wanted people to take away. We really want the learners to take away, how do you change your clinical practice? How do you bring up the conversation? And how do you make sure you're accessing all the resources available to you? So that was the importance of this case. But again, they really engaged in discussion during this time. And that was really important. So next slide. So did it work better? Yes, yes, it did. We had, and like I mentioned, we had the true false questions. We had, I think, maybe 3 or 4 or so, and they were sprinkled around. So that way people were still participating throughout the whole thing. The case we just did was at the very end. We were able to have more discussion about reintegration. We provided more skills and resources. We actually gave them a handout afterwards that listed some of the social work contacts. So some of the information does not always have to be included in the lecture, and handouts can be useful. We felt that this version provided more skills and resources that could be directly utilized in the clinical setting. And then again, we put more focus on understanding when to refer and how to refer. And so lessons learned overall during this entire thing is that there are a lot of lessons learned. Keep in mind, we had to pivot a lot of things for the pandemic, for it to be virtual, all of that. So that's that was a challenge in and of itself. But I think we included this one first. The biggest thing is, don't assume that everyone has the same lived experiences. And that's why we started with, again, highlighting what some may consider basic knowledge, like what's the difference between jail and prison, but you can't have a lecture if we don't have the same foundation. So as you're developing your own lectures, not making any assumptions about people's lived experiences, choosing the most high yield data. So for us to sort of recap, we wanted to make sure that our learners were learning about the general population statistics, but also definitely about our veterans and the things that affect our veterans, the challenges they have as they're reintegrating, not just, they've already had to reintegrate into civilian society after leaving the military, but then to have to do this again in a different context puts them in a unique patient population. Also, understanding what VA specific resources they have was important to us. So we chose the high yield information that is the most clinically relevant for them. And then we also wanted to make sure that we're choosing the information that is the most engaging, because at the end of the day, any education curricular activity that you do, you want to make sure that people actually walk away with the goals you had in mind, walk away with the information, that you had in mind. So we wanted them to walk away with what are current statistics in our country, why is there such mass incarceration, what factors are leading to that, how has it been changing over time, how is it specific to our veterans, and then what clinical issues will you see in your practice as you're taking care of different types of patients. And so those were the things we kept in mind as we revamped and redid the lecture. And we also wanted to really make sure they walked away feeling like the goal of COE in general is to make sure that we are really using all of our colleagues to their highest professional engagement. And so we wanted to make sure that we are teaching this as we're teaching to a group of interdisciplinary learners, that we're also actually using the resources that they all can provide, and not just thinking, well, our social workers can only do this one aspect of things. Absolutely not. Our social workers have a wealth of information and they know how to navigate the system. And are we using our pharmacists to their highest potentials? Our pharmacy colleagues they have access to things and data and formularies that we don't know about. So are we using them? If our patient does have to choose between court fees and paying for medications, are we utilizing our pharmacists to help us figure out how can we get something at a lower cost? Are there discount programs? Are there whatever it may be? Or is there an alternative medication we can use? And so we really wanted the learners to focus on utilizing each other as resources and figuring out what the hospital resources were. And so next slide, please. So future directions for not just this, but for our whole curriculum. We have recently revamped our survey and evaluation process so that we can get more robust data from the learners. We are looking to ensure that they are still utilizing the things that they learned from this lecture. We really want to add more case-based discussions or clinical scenarios. I think that would, people remember stories. We all remember stories, and that really helps. So adding more case-based discussions, and we're really trying to build more community partnerships at this time. As you all know, none of us can work in a silo. And so there are already so many community programs that have been historically looking at this, helping and have even more in-depth knowledge. So we are in the future focusing more on building community partnerships. And then, as always with any new lecture, making sure that we have current statistical information, making sure we fully understand the scope of the problem, any changes that have been made there, their laws change all the time, making sure that we fully understand that. And so I think that overall, where we are at with this lecture it's in a really good place, but there's always room for improvement. And I think that's the last slide, actually. Yeah.